right, everyone, we're going to go ahead and get started. So, welcome. My name is Felicidad, and I'm the Communication and Resolution Program Manager with the Foundation for Healthcare Quality. Thank you so much for joining today's session, Errors, Emotions, and Ethics, CRP, and Caring for the Caregiver. We have a very exciting and informative presentation today, so I'll be quickly going over some housekeeping, share a little bit about the foundation and our CRP work, then pass it over to our speaker. So, very brief housekeeping. Please keep your mics on mute. We will have time for questions at the end of the presentation, which at that point, you're welcome to type any questions you have in the chat or come off mute to ask your question. This webinar is being recorded, and the recording and slides will be sent to all registrants once they are available. All right, so here are the learning objectives for today's session. We're going to go over the evolution of the national movement for patient safety, explore how supporting providers after harm aligns with the essential elements of CRP, understand the emotional and psychological impact of adverse medical events on healthcare professionals, recognize the organizational and patient safety benefits of proactively addressing provider well-being after medical harm, and finally, we will examine a real-world example of a successful Care for the Caregiver program and the best practices they developed for integrating emotional support into their health system. But first, to quickly share a little bit about the Foundation for Healthcare Quality, we are a nonprofit certified patient safety organization based in Seattle. The Foundation is a trusted third-party resource that is available to all participants within the healthcare community. With our designation as a patient safety organization, us federal level confidentiality protection that allows us to expand the use and participation of our programs nationwide. Here in Washington, we also have state-level confidentiality protections under Washington's Coordinated Quality Improvement Program, otherwise known as CQIP. The Foundation houses a variety of programs focusing on innovative and data-driven concepts such as measuring and enhancing healthcare quality, improving patient safety, and responding to adverse events with transparency and compassion. One of the programs housed within the Foundation is our Communication and Resolution Certification Program, which aims to increase education and awareness of CRPs and foster consistent utilization of the CRP process. Outside of our broad educational activities, we also offer 2 pathways for free and confidential CRP case reviews by a panel of peers who will provide thoughtful and actionable feedback, support you in strengthening your CRP, and you'd be able to compare your approach to other organizations. Our CRP certification program is endorsed by the Washington Medical Commission. And if you've been keeping up with what's been happening nationally with the patient safety structural measure, both of these services can be a great tool in supporting you in attesting yes to the CRP domain of the patient safety structural measure that I will briefly summarize in the next slide. So if you have any questions about our CRP work, feel free to contact me. My email is listed here at the bottom of this slide. Okay, so for the Center for Medicare and Medicaid Services Patient Safety Structural Measure, it was released late last year as an attestation model for healthcare organizations to affirm their use and implementation of 5 domains of best practices in patient safety. So most relevant to the Foundation's CRP work and today's discussion is Domain 4 of the structural measure, accountability and transparency. Within this domain, one of the things hospitals can attest to is if they have a defined evidence-based communication and resolution program in use after harm events that contains all of the essential elements of CRP. So that includes harm event identification, transparent and ongoing communication with the patient and their family, event investigation, care for the caregiver, and post-event reconciliation. So today will heavily revolve around the care for the caregiver aspect of CRP and I hope that you all will enjoy today's exploration of this immensely important topic. So, without further ado, it is with great honor that I introduce today's speaker, Dr. Susan Scott. So, Dr. Scott is a nurse scientist at the University of Missouri Healthcare and an adjunct associate professor at the Sinclair School of Nursing. Her research focuses on healthcare workforce well being and the development of institutional support systems for clinicians following emotionally challenging events. Dr. Scott's pioneering work defined the second victim phenomenon and led to the creation of the forYOU team, the first peer support network of its kind. She's published extensively in peer reviewed journals on clinician trauma and has collaborated with leading agencies such as the Agency for Healthcare Research and Quality, the American Hospital Association, the Joint Commission, and the Institute for Healthcare Improvement to promote accessible, evidence based support for healthcare workers around the world. Dr. Scott, the floor is yours.
Okay. Thank you, Felicity. Felicity, can you just verify you can see the screen okay?
Yes, looks great.
Okay, perfect, perfect. Well, hello everyone, and greetings from Columbia, Missouri. I'd really like to thank the Foundation for Healthcare Quality and Felicidad for the invitation to share insights over our collective learning over almost 20 years now, where we've been working with our team members after challenging clinical events. So I'm looking forward to our conversation today. If you have any questions, I'm hoping to leave some room at the very end for questions. So if you want to enter them into the chat, I'll let Felicity kind of monitor that for me, and then if there are any, we'll respond to them at the very end. So for disclosures, I do not have any relevant financial relationships with any commercial interests, so that's okay. Felicity nicely went through our learner objectives, so I'm not going to belabor that. But basically, my goal today is to review and share with you in 45 minutes what we've learned in the last 20 years on helping care for distressed caregivers and how to help promote their well-being and career well-being. I've learned as an individual in patient safety, deeply immersed in patient safety, that when we have these emotionally challenging clinical events and we have staff members that have are evoked an emotional response, I realized that staff really don't know what's happening to them at the time. The concept hasn't been socialized very well. We're starting to make some great inroads into that, but the topic of second victim is one that's not known by many. When what I've learned is that probably in any given productive healthcare career, we'll probably have between 4 to 6 specific clinical events of that one special patient that really caused you distress and concern and probably reflection on that care maybe to this day. Um, we also learned that individuals that are closest to that person, so their professional social networks, their colleagues, their coworkers, their peers, really don't know what to say or how to approach the individual. So many times they don't say anything at all, or they talk about, wow, did you see that storm we had here in Columbia this morning? Wow, that was intense, wasn't it? And so, kind of avoiding the elephant in the room. So, my whole goal in sharing our insights and our knowledge is twofold: to increase the socialization and the concept of what this lived experience is like for our hardworking healthcare workforce, as well as share insights into what we could do as peers, coworkers, leaders. And most of all, what could an institution do to help provide a supportive infrastructure to promote a healthy career wellness trajectory for that individual? I'd like to just share how I got started down this road. In 2003, I was offered one of the first patient safety officer positions at MU Healthcare. So, as a chronologically gifted RN, I was really excited to take on a new challenge. I felt like I was really ready after fulfilling several roles in both bedside and leadership capacity within our nursing departments. Um, and so when I had my first opportunity to review a pretty serious operative error in the perioperative suite, I actually was a little bit, I felt good that I actually had an opportunity to work with a clinician that I had known for decades, literally working in the newborn intensive care unit. And so I met with this individual about 36 hours after the event happened in his operating room. And we met, and it was a very relaxed conversation at first. He was very poised. He shared his information. And, as his reputation and my experience with him preceded it, very meticulously done. He had met closely with the patient and the family members. He had told them what had transpired. He had shared with them that they could transfer care to another clinician or to another facility. uh, the wife had so much respect for this gentleman that the wife was the injured party. The husband said, I really think her desire would be to stay with you, and to maximize what wellness we can have. And so he met with them regularly, and kept them posted on progress or on digression. He was very interactive and communicative with them. He also worked with the equipment company, the vendor. He reached out. He had not talked to them yet, but he wanted to talk to the design engineer to share some insights to help protect the future clinician and the future patients. He thought maybe a human factors kind of format actually make a difference. And he had just left lunch. He went to lunch. He took the medical student that was working with him on the case. He was grooming her to apply for a surgical residency. And he really felt like this one case might sabotage that career path for her. And so he spent time with her at lunch just to see how she was doing, to give her an opportunity to talk through her lived experience, what her emotions were like, and just kind of reassuring her that, how she was reacting was perfectly a normal human response. So he had really done a lot. And so we had had a nice conversation. We had talked for about an hour and 20 minutes. At the very end of the conversation, I looked at him and I said, I know that had to be hard on you. How are you doing? And he looked at me and he started sobbing. And I reached into what I thought was a fairly good, mature communication toolkit that felt incredibly empty. How would I help this gentleman who's sitting in front of me, who I deeply respect, make it different? How can I make a difference for him? How can I offer a supportive presence for him? And so, after what felt like a very long time, in the heat of the moment, those seconds go so slowly. Um, but I told him, I said, this one case doesn't change my mind about what an incredible surgeon you are. And I'm in awe of your skill set. Heaven forbid if I'm on that OR table tonight, I hope that I look up and I see that it's you, because that's what I'd really want. And so somehow that made him feel a little bit better, but it didn't really make me feel better. We ended our conversation and he was tucked together and quite professional and walked out just like nothing had transpired 5 minutes before. But when I debriefed with my chief medical officer, I told him, I said, I don't know. I said, I feel like, there's really nothing as assistance perspective we could do in addition to what he's already done. They've got it taken care of. Risk management's involved. I think we're going to be okay. But I said, I'm struggling as a novice patient safety officer. Um, I felt a bit inadequate. I wasn't sure how to help support that person. And so my mentor at the time, the chief medical officer, said, I think I know what you're talking about, Sue. I think you're talking about a second victim." I said, "A second victim? I've never heard that term before. Can you tell me more?" And so he turned around and he opened his drawer and he pulled out a page and a half editorial. It was an editorial from a 2000 British Medical Journal in which we were formally introducing the Tuera's Human Report to the masses. And in that editorial, Dr. Albert Wu, an internist from Johns Hopkins, actually talked about that there's so many individual patients that we're harming, but we can't lose a focus on how to prevent and address future errors. But we also need to keep in mind our well-intended staff members. And he so eloquently described how he was working with a colleague, a co-resident, who was really ostracized and judged very harshly by his jury of peers regarding the misinterpretation of an EKG. And that's when the term second victim was coined. Albert said, "Please don't forget the first victim, the patient and family members, but also remember the second victim, our staff members." So the term was coined at that point. Um, I About a week later, I had my second huge case that I had to work on. It was an unexpected patient death in an outpatient minor OR procedure, and um, I worked with the individual. We did, because of the complexity of the patient's care, he was a very long-term patient of ours suffering from advanced metastatic cancer disease. And he, his wife, when asked her about an autopsy, denied an autopsy. So we'll really never know the cause of death. The best, uh, the best medical review that we got from two independent clinicians thought that probably the patient died from a pulmonary embolism, but we'll never know. But when I interviewed, I reached out for the interventional radiologist, and they weren't there on that Monday. This occurred on a Friday. So I reached out to the nurse that was involved in providing the sedatives to the patient who required very little sedation. And when he walked into my area, my work area, I was shocked to see how disheveled this young man looked. I'd known him for a long time, a well-respected intensive care unit nurse, a meticulous reputation. And he started sharing his story about how he had not slept longer than 10 minutes at a time since last Thursday night before he went to work on that Friday morning. And he felt like he was having a psychiatric breakdown. Um, what he kind of shared with me, his symptoms were so similar to what the surgeon had just shared with me, like just a few days before. And I felt like maybe my toolkit had a little more information now. I said, "I think that you're suffering as a second victim." And I've heard of others that have done that. In fact, I recently worked with another individual who was really deeply impacted by that event. And you could almost see the shoulders relax. This gentleman, I'll refer to him as Tony. That's not his real name, but Tony relaxed his shoulders, and Tony said, "I really thought I was having a psychiatric crisis. I can't stop thinking about this patient. I can't figure out what I've done wrong. I just keep thinking and hoping that maybe I can envision how I can help my next patient. What could I have done wrong?" And was doing a lot of self-blame. But by the fact I just said that I had just talked to someone else who was feeling very similar was very comforting in a way. Still felt like I needed to do a little bit more information. And as I continued working with staff members, I um, I could close my eyes. It could be a male or female. It could be a nurse, or it could be the most respected surgeon at our facility. It could be a rookie, or it could be most senior. It really didn't matter. As humans called to this incredibly wonderful profession of healthcare, um, they have some deep visceral pain when their patient has an unexpected patient outcome. You can see some of those quotes that I've heard, and you may have even heard those yourself. It felt like we needed to start figuring out more and more about this concept of second victim. I started a literature review, and the only thing I could find was that one article that described second victim. But I did find some articles from the 80s and 90s and very early 2000 describing the intense emotional response of individual physicians related to medical errors. And I did find one article by a nurse, an anonymous nurse, who still to that day still felt like she might lose her job because of her involvement in a patient medication overdose. But there was really no literature. So since then, the literature has just blown up. I mean, it's been incredible how we've taken initial research opportunities, and in the spirit of scientific inquiry, we keep growing and gaining our knowledge. So um, one my goal for today is to share that 20-year journey in a very kind of a quick format, I guess so, for the less than 30 minutes left. Um, I really am intrigued by this slide. This is this is all perioperative, so these are anesthesiology focused questionnaires. There's 4 different studies here that were conducted between 12 and 19. It really doesn't matter which bar we're looking at, but one is a department only from a very large Eastern Hospital academic medical center. Another one is from the state. A second one is from a separate academic center. And then the fourth one is actually a national survey of anesthesiologists talking about how long did it take them to recover emotionally after they've experienced firsthand a perioperative catastrophe. And I think that this starts to kind of build our business case about how important it is that we need to think about um, how, as healthcare entities, we can help support our staff and encourage the career well being for them so they can have successful lives. It's striking to me that about 1 in 5 have never completely recovered from their perioperative catastrophe. And that's almost replicated 4 times. So I think that that's pretty interesting statistics. Like I said, there's been a lot of studies that have come out. One was a meta-analysis where they looked at 18 studies where we, as a healthcare industry, we did deep dives on the physical and psychosocial responses of our healthcare workforce. So this is just under 12,000 providers. And what their responses were after their initial involvement within an adverse and this is related specifically to a medical error event. I don't think as you look at the responses that you'll really see any surprises there. I mean, at least I wasn't surprised. Yes, I've heard it. Yes, I've heard it. I've heard it in their voices. I've seen it in their faces. I think what really shocked me was the high percentages. 8 and 10 have troubling memories. 3/4 have anxiety, concern, and worry about continuing to do their jobs. If if as humans and as if these close to 12,000 people responded almost similarly, if that's that predictable, can't we as healthcare organizations form rapid response teams to address the needs of our suffering clinicians before they even realize that before they even had that first sleepless night? What can we do to provide that safe zone so that we could encourage individuals and promote the healing process first, but before they actually start feeling these emotions? So this was the initial study in 2012. We talked to individuals and we identified there's some high risk scenarios that could evoke a second victim response. I know in patient safety, we do a lot of correlations with aviation safety. You might want to think of these as red flags. If you have one red flag in aviation, you need to kind of be heightened alertness. If you have a second red flag, tell a buddy, something, I'm a little worried about this scenario. We need all hands on deck just to keep attuned and keep familiar with what's transpiring. 3, chances are really good you're going to have an accident. 3, chances are really good you're going to have a second victim reaction. So let me just quickly go over these. The first one happens almost every single time I work with an individual who's suffering in the aftermath of one of these challenging events. And that is they somehow connect themselves to that individual patient and their own family. So this could happen in a lot of different ways. We not too long ago had a young man in his young 40s that collapsed and had a massive MI in our hospital lobby. And the rapid response team that responded to this gentleman had 2 nurses. Um, Both nurses were deeply impacted by this event and requested just a conversation with a peer supporter. The first one had shared the same date of birth and had a similar body habitus. That could have been him on the floor, is kind of pretty much the bottom line of his worries that really deeply impacted him. The second one, Columbia is a small town, 150,000 with its students, but people know each other. And the second responder actually knew this individual as a friend and so was deeply impacted by that. But there's other ways that people could connect through the gift of time, especially in um, like rural community ambulatory settings where uh, the same people come in every day for their PCPs, and you get to know them over decades of care. Other gifts of time would include things like in vitro fertilization patients or hematology oncology patients. Probably the most demonstrative way I've seen a staff connect um, to the patient was the patient had they many times they have same names or same date of birth or same diagnosis. I recently talked to a nurse and she said that was on the year of her mom's death, and she walked into the intensive care unit and she heard a death rattle coming from bed 2, the same death rattle she just experienced a year before. So there's a lot of different ways people can connect. So and you might be reflecting on your own personal healthcare careers. Think about that one special patient and how did I connect to that person? Pediatric cases are always difficult. In fact, if we have a pediatric death, we actually automatically offer group debriefings where the team can talk about the lived experience of caring for that child. Medical errors, for sure, cause just staff distress. Failure to rescue cases and first death experiences, we're finding a lot, especially with the newness of all of our team members. That's been a real hardship for a lot of our new graduates, especially as they're kind of tackling the transition shock that they're experiencing. Having that first death experience is really hard. If we'd replicate this study today, I think that you could also include another red flag of exposure to workplace violence events. In fact, I talked to a hospital the other day. They said 1 in 2 of their peer encounters now relates to aggressive, assaultive patient family abuse on staff members. So it's kind of interesting to see how those dynamics have shifted over time. Because of that, we've actually revised our definition of what is a second victim. Initially, I wrote one in 2006, and it was defined as pretty myopically focused on patient safety medical errors. That was my role. It felt like everybody had medical errors that I was engaging with. But since then, we've learned that healthcare is so much more complicated than that, and there's so many other things that could traumatize that healthcare worker. So we've got the definition revised to second victims are individuals working within an environment offering care, and they're personally or professionally traumatized by exposure to that emotionally challenging clinical event. You might want to ask, Sue, how are you defining your challenging clinical events? I found at the 12-year mark of our peer support team's existence that we actually had 3 really distinct buckets of events. Um, the vast majority, about 54%, are unexpected clinical events. Those things like the motor vehicle collision in which the mom and the father are killed in the front seat and the kids in the back are all fine. Or the labor and delivery nurse that admits the scheduled C-section term lady healthy for her C-section later that day, only to find when she puts on the fetal monitor that there's a fetal demise. Um, those things that happen within our settings that are no fault at all to the team members themselves, but and no errors are involved, but they're exposed to that scenario. Second is tragic clinician events. We've seen a lot. Well, initially we had what brought our attention to this was we had a death by suicide of a young ICU nurse, and um, sadly we had a kind of like a bunch. We had probably 18 in 1 year of individuals that had either catastrophic diagnosis and were dying, or acute experiences where they die, um, and they're all part of the active workforce. We could also include in this group, we included sharp injuries when we were kind of having sharp injuries at the beginning of the 2000s. Um, but more recently, we've also added workplace violence exposure, the emotional harm related to that. And then last but not least, only accounting for about 10 percent of our total encounters is medical errors. So staff that were at the sharp end of the mistake. We learned that there's a real specific way that individuals recover when they come from after these events. And this has actually been replicated in multiple cultures and in different nationalities. And what we found is that there are 6 stages. It's not important to remember the name of each stage. That doesn't really, it's not important at all. But what's important is to know that your healthcare work team member has a different need in each one of these stages. And if we're aware of that, then as an institution, as a peer, as a leader, or as an organizational leader, we can design infrastructure in place to help support that. Stage 6 is unique. It's an outcome stage. Originally, I really thought this was a proxy for how well the individual healed from that exposure to that event. Um, I've now shifted my thought significantly, and it's actually a proxy on how well that local department and our organization helped address the needs of that staff member. So it's not the staff member, it's not a reflection of the staff member, it's a reflection on how well we did in providing that supportive presence. There's 3 different outcomes in the moving on stage 6. It's thriving, surviving, and dropping out. I'll share a little bit about that. But just to go over these really quickly, the title at the top is the name of the stage. Characteristics are also included on the stage. The quotes are quotes from our initial qualitative work where we ask 31 individuals, 11 nurses, 10 physicians, and 10 others, physical therapists, respiratory therapy, student learners, etc. And these are some quotes that represent this particular stage. I just started working with a doctoral student at Ottawa University, and she's doing a phenomenological study with medical students or with physicians, practicing physicians, in which they want to validate these stages by through the form of art or music or poetry. And so it's very intriguing. This is not the students' work. These are what I kind of picked out if I was doing her exercise, how I would fill out the stages. But sometimes pictures are worth 1,000 words, and they help us remember what we need to be thinking about. The second stage, I'm sorry, the first stage, chaos and exit response, starts the moment that the individual recognizes something has transpired on their watch until they turn the care over to somebody else. You may think of episodes where you've had an emergency on your floor and you walk up and the individual at the bedside at the time is kind of giving a very choppy, chaotic report. Chances are good they're in the chaos and accident response. Their mind's thinking 1,000 times a minute while they're trying to react and stabilize. Um, the clinician is really distracted at this point, and you might even have to ask questions more than once to get an answer from them. I talked to a paramedic who was doing prolonged CPR on a drowning pediatric patient um, coming to the hospital, and he said he was doing chest compressions, but the whole time it was almost like an out of body experience. He could see that he was doing the compressions, but his mind was racing on what else can we do? Is there any other center closer I can get him to? What are my choices? And he had a very prolonged chaos and accident response. He had about a 32-minute stage. Most people in the hospital setting have a very short phase. It's just from the time it's recognized until the care is turned over to somebody else. Stage 2, intrusive reflections, is truly the most dangerous stage of all 6. And in this intrusive reflections, once the care is given to somebody else, that's when they start mulling over the care of the patient. What did they miss? What would any other student nurse have seen? What would any other surgeon have done differently? They start asking all of these self doubt questions, and they start really actually planting seeds of self doubt. And if this stage isn't interrupted, these seeds start to flourish, and the feelings of the internal inadequacy that that person has is immense. It leads to comments like the one on that one quote page where it said, I'm going to go to Walmart and be a greeter. I can't mess somebody's life up like I did yesterday. So we really need to be interruptive in this stage and try to be a supportive presence for that person. Stage 3 is restoring personal integrity. They still want to be a trusted member of the team. They want to be appreciated, valued, and respected. They don't want to be the topic of tomorrow's hospital grapevine gossip. Um, their fear is so prevalent. They have a fear of the unknown, and they fear so many different things. They're not even sure how to label some of the fears that they have, like what happens next? What should I worry about? Is there going to be a lawsuit? What's the family say? There's just a lot of fear. And so, just the little thing I said to my surgeon colleague, I hope you're at the head of that OR table tonight, should I need you, was reassuring. It showed that I still respected him and admired his skill set. And during the Inquisition, is especially pertinent for individuals that have experienced a medical error and are um, were intimately involved in a workplace violence event within their work settings. So a lot of times they meet with individuals they don't know, and and that just kind of fosters that fear of the unknown, and kind of magnifies that fear. They talk to people they don't know who they're even talking to. In many cases, it could be an institutional representative, um, but knowing that they're going through such emotional turmoil, and this is where the stress levels really get really, really high, and that's where you many times start to see the breakdown and start to see the actual physical and psychosocial symptoms appearing by that individual. The next stage is fascinating. I wish I had more time in my life to study it, but it's called obtaining emotional first aid. As healthcare workers, we're really good at being helpers, but we usually listen to a sentence, and then by halfway through, we got to roll our sleeves rolled up and we're ready to start intervening. But we're really bad at being the helpee. What we found is only about 15% of healthcare workers will ask for help on their own behalf. The others do what I would call hinting and hoping. They hope that somebody reaches out, that somebody might realize that, man, Sue's off today, or boy, Felicity's awfully quiet today. Oh, she had that rough case yesterday. Wonder if she needs some help. But these individuals, they want help desperately. They don't want to have to ask for it. So when places start out with hotlines and pagers, and just realize you're only going to be addressing about 15% of your workforce, that the other 85%, you got to have a way to surveil so you could proactively reach out to help support them. Stage 6, the moving on stage, that's the outcome stage. Thriving is the best outcome we can have. It truly is a form of post-traumatic growth for these individuals. Remember my surgeon, he reached out to the equipment design team. He wanted to make something positive come out of that very horrific case. And many people asked me if I would include the frontline staff in a case review, a formal RCA. And I think it's helpful for their healing. I think that if they're healed enough that they could be there and listen to the conversation and contribute in a meaningful way to system changes, I think that actually helps push them into being a thriver. They want to make sure that they can see that something positive has come out of this very horrific thing. Surviving is a fascinating outcome in that um, people are just coping. Um, they You have a baseline performance that kind of plummets after the event, and they're never quite the same since that day. Their performance never gets back to that same level. Many of them will tell you that I can't give my all again and get hurt like I got hurt that time. And so, um, what we want to do with this is we want to try to figure out a way to stimulate, encourage involvement so that they can maybe help future action steps, maybe to help make things better. What we've learned from this is they're actually practicing a social science term called presenteeism, where you're kind of there, but you're not really there 100%. Dropping out are the ones that I really worry about. For the dropouts, those are the individuals that have a career change. They change their career path because of one specific event. So they might go to a different department. They might go from being a circulating nurse in the OR to teaching scrub techs. They do things where they can protect their heart, is what one person said. So they just kind of figure out what they could do differently. Usually still in the healthcare environment, but sometimes not. But they try to figure out how can they transfer, do something different. Dropouts are an interesting group to study because once they leave your facility, they're gone. So we launched a social survey using social media, and we had over 700 people reply from around the country, around the world. 9 countries were represented. Vast majority were in inpatient care, not surprising. I think what was kind of an alert to me was that a fourth of those people are in the ambulatory care setting, are in the pre-hospital critical care transport kind of settings. 50% were direct care providers. That number seemed low to me. The other 50% were all in the supervisory capacities of individuals who had been involved in an event. And because of that event, they couldn't continue their roles. Either they were primarily supervisors, but a small percentage of them, about a fourth of them, were actually educators who were responsible for student learners, and the student learner was involved in the event. 60% assumed roles with less or equal risk to similar exposure. So we would selectively pick a role that they felt like they wouldn't be exposed to that type of clinical event ever again. This is Dr. Wu. You heard his name earlier. He's a gentleman that coined the term second victim. We did a conference together for the American Medical Society, and he started out by saying it's not a matter of if clinicians are going to experience trauma while providing care, but when and how often. And I just like to ask the personal question, add to this, how prepared are you and your facility to address those needs? So we've learned through a lot of the research what they want in support. We need 3 basic things. They want to minimize the human toll that we've been experiencing for decades, provide a safe zone for individuals so that they can receive the support that they need, and be confident that they're not going to be the topic of tomorrow's grapevine gossip. So confidentiality for this kind of support is so critically important. And then how can we, we had we have a rapid response teams for patients that are declining rapidly, or we have emotional exacerbation response teams. Why don't we have a response team that could address emotional first aid for our well deserving healthcare workforce who's suffering as a second victim? Combining about 4 research projects, we realized we learned what people wanted in the aftermath of these events. And by doing that, we formed a peer support infrastructure. It's called the forYOU team. If you want some more information, the web address is on this slide. But we realized that we needed to offer 2 different types of support is what staff wanted. They wanted one-on-one support. And when a whole team was impacted by an event, they desperately wanted some kind of a group debrief where they could like talk a little bit about what that lived experience was like for the group. So we formed a pyramid of support services with the base being the broadest amount of support. About 60% of support can come from that local leadership support that understands what a second victim is, what they look like, and offer that supportive presence, primarily by addressing all those fears of the unknown. Remember, we talked about that. They know they can introduce the individual to the risk manager, to the patient safety officer. They can help support them as they write their incident reports. There's so much that tier 1 can do. We're anticipating about 60% could take care of that. So when I designed this pyramid of support, I really designed it after our emergency medical services model in a way. So tier 1 you could think of as basic first aid skills that we learned as Girl Scouts and Boy Scouts, how to handle a basic emergency. But you know, if it's still bleeding and I'm not happy with it, I feel uncomfortable at all, I'm going to call an ambulance, which is tier 2. Tier 2 is where we have trained peer supporters who are activated throughout our healthcare system, inpatient, outpatient, you name it, and every discipline is represented, or as many as we can get. Um, and they offer the one-on-one peer support in Tier 2. We also offer uh, group debriefings in Tier 2. But we also know there's going to be a few needs of clinicians that exceed capabilities of even that knowledgeable peer supporter and the well-informed local leader. So, tier 3 is where we've expedited a referral process for our internal mental health individuals. So, folks like many people use employee assistance programs, but there's other resources, chaplains if they have a spiritual crisis, social work, clinical psychologists. We had a wellness nurse, a holistic nurse who helped some of the non clinical workforce members who are suffering understand stress management and self care. So about 10%, 10 to 13% will need tier 3 support. So we tried to package it so that we could get the help when we needed it, as soon as they recognize that there was a need, and get the expert help as quickly as we could. So if you're into conceptual models, all along what we had was these unanticipated events and these second victim reactions, which for decades have been stifled. And what we call emotional labor, where individuals just kind of their emotive response is different from what they feel in their guts. And so we realized we needed to implement a purposeful habit, an intervention of sorts. And so having a formal institutional response plan, forming the rapid response team of our forYOU team was our intervention to help promote clinician recovery in one of those three directions with the hope of having it at least survive, if not thrive. Human behavior is really interesting, though. It takes a while for culture to change. First, you have to have that habit, purposeful intervention introduced. And then pretty soon you'll see behavioral shifts. People will start supporting each other. And before you know it, well, 7 to 10 years later is what the scientists say as for a pure cultural transformation. Um, but you'll see that pure cultural transformation. We've learned what they want, what clinicians want. They want to feel appreciated, valued, respected, understood, but they most importantly really want to be a trusted member of the team. And you might say, Sue, these are needs that every human really has. And I would argue back that the needs that the second victims have are on steroids. They need to hear it from a lot of different people. That surgeon needed to hear from more than just Sue Scott saying, I admire your skills. This one case has not changed my mind. They need to hear it from their coworkers. But we've learned that there's barriers to receiving support. There is still a real stigma associated with reaching out for help. Now, there's been a shift. I can perceive a shift, especially post COVID, where well being is really becoming more of an epicenter of focus. And maybe more than 15% of people will start asking for help on their own behalf because of that COVID experience. At least I hope so. But there's still a stigma related to that. Lack of time. Everybody's incredibly busy. Who can they access? Can they trust them to maintain that confidential spin on things? They don't want to lose their integrity as not being a trusted member of the team. And then we have so many personal and societal expectations on these people. I mean, healthcare workers are supposed to be providing 100% accurate care. And as fallible humans, we have our vulnerabilities. And so our own personal vulnerability of not making any mistakes is really detrimental to that individual when a mistake does happen. These second victims really frequently feel that they're responsible for that outcome in an exaggerated way. They all feel like they failed the patient. They second guess their clinical skills. They're always saying, I wish I could have or wish I should have done more. And so understanding that those kind of feelings is also helpful when you're interacting with somebody in that phase. I really have started using and embracing this combat and operational continuum stress model. This is actually designed by the military as a self check to see how you're doing. But I also think that we could use it in a post-event evaluations where we could look at each other. So if we have an event and we monitor that individual and interact with them and they're fine, then we go on with our day. But if we start, my goal is to have interventional support before signs of distress show up. But sadly, many times signs of distress show up pretty quickly before we can intervene. And so, if we are starting to see signs of distress in yellow or maybe even orange, then we need to really form an interventional support strategy for that individual uh, so that we can promote their healing processes. I'd like to share some data with you. I need to tell you that this data has not undergone peer review. It's not been in a publication yet. I've been working on it, but it's very insightful on the perceived supportive work environment and the changes that you can see in your personnel. So this is data from a modified ARC survey, hospital survey on patient safety. And there's a total of 118 different facilities throughout the country. It's almost 70, a little over 73,000 responders, including 4,000 are physicians. But the timing is a little bit weird in that it was administered just prior to the pandemic. So what we did was we modified the survey tool, adding a couple questions. We looked at second victim prevalence. We looked at staff perception of patient safety. So in the ARC survey tool, there's exactly 10 dimensions, and so we look at differences there. And then the Institute for Healthcare Improvements have joy in work. They have 5 questions, so we adapted that. So the first question, just to start finding our populations, where within the past year, did a patient safety event cause you to experience anxiety, depression, or wondering if you were able to continue to do your job? About 15% said yes. That's probably about an average. It depends on the population for sure. If you're going to be doing a trauma ICU, you can expect much higher scores, prevalence there. If you're doing an outpatient family practice clinic, that probably is too high. So it really depends on the population. But as an overall population, 15%, 1 in 6, 1 in 7 of our coworkers, that makes sense to me. The follow-up question, if they said yes, was, did you receive support? And this makes my heart smile. This is incredible results. 50% said yes. Oh, I'm sorry. There's yes, yes. I've got to fix that. Sorry about that. 50% said yes, 50% said no. When I give this survey to hospitals when they're thinking about offering supportive presence, it's almost always in the 20 to low 30% range. So this is really good. Initially, I was hoping for 100%, but there is a population. About 25% of our care team members would prefer not to get help internally. They would prefer to do their own personal social networks as opposed to their professional social networks. So target goal of over 60 is like ideal. I think that could be our target. So real quick, this is the culture survey results. The x-axis are the 10 dimensions. There's like 4 questions rolled up into each one of those dimensions, and it's 0 to 100%. And you can see that individuals that declared themselves as non-second victims had pretty high perceptions of um, uh, the patient safety for their work areas. The second victims themselves kind of are a little bit lower. And if you actually divide out the second victims with support and without support, which I'm kind of still working on, there's a huge difference between those populations as well. They're all statistically significant and clinically meaningful. The joy in work we've got split out already by the 3. And so the 5 questions are listed there. I'm not going to bother to read them to you. But what you can see is that the individual that does not have this experience within the last year has a very high perception of satisfaction and joy and meaning. The second victim is a little bit lower. The lowest bar are the ones that were not supported. In fact, they're actually detractors if you look at net promoter scores as well. I'd like to look at a quick, I know I'm getting down on time, so I'm going to pick up pace a little bit. These are some unit-based results, and what I'd just like to do is show you Unit B, the impacted clinical prevalence means clinician prevalence means the second victim. So in this unit, 64% in 1 year said that they had experienced a second victim response. The next column, they only 13% received support. The fourth column is unit safety grade 2.64 compared to our overall for our hospital of 4.10. So you can see that really significantly impacts overall communication and teamwork when you have clinicians that don't feel supported after these events. Compared to Unit D, 56% prevalence, pretty high. Perceived support, 72%. Highest score I've ever seen. It's amazing. One of the higher scores. Unit safety score, much higher than our overall score. So I always like to end these conversations with if for the clinicians on the call, when I become a second victim, what are some self-care strategies you could deploy proactively? Develop a perk file and periodically reflect on some of your happier clinical experiences. It's amazing when these people are in the deepest, darkest hours of their professional lives, they forget that they've done anything positive. But to have that perk file just to sit and emulate through as they're recovering is so helpful. Um, Practice self care before you need it urgently. And if you do have a second victim experience, lean into that self care. Is it jogging? Is it aromatherapy? Is it self reflections, meditations? Is it writing, journaling? Lean into that. You deserve that. Many people suffering a second victim still feel like they deserve it. Develop a strong social network now. In fact, kind of think about who could be a trusted colleague who could help you through this type of situation. Though know that it's not okay to be okay, not to be okay after a challenging event, and know that you're not alone. It feels very lonely when you're suffering like that and you look around and you don't see anybody else hurting. So what you can do differently tomorrow is understand the concept of second victim, talk about the second victim concept, spread the word. Awareness truly is the first intervention. Take these slides, Felicidad has a copy of them. She's going to post them. Please take them and use them and make them your own. Um, Determine a way that you can make a personal difference for these folks in whatever role you have. If you're the patient safety officer who's investigating a case, or if you're the risk manager who's helped supporting through a protracted litigation process. If you're worried about somebody, please reach out. And almost every one of these talks I give, somebody's thinking about a coworker back home that they need to reach out to. And the bottom line is just to be there for your colleague. Sometimes just silent presence is really all they need. But by being there, you show that you still respect and trust them and you want to be their colleague. So with that, I'll open it up for questions.
What a fantastic presentation. So I'm so grateful to have had you here. So if anybody has any questions, please feel free to use the chat or pop off mute if you would like. We don't really have much time, but if I can
Sorry.
squeeze a question in, no, we loved it. It was fabulous. So I just have one super quick question. Is there any emerging research or innovations that you're excited about in this field of care for the caregiver or the second victim response that you're looking forward to and that you're super excited about?
So we're actually doing a data analysis right now on a Delphi study that we did with existing peer support teams throughout their country. So there's 31 healthcare teams that have peer support teams in place, and they're giving us tips and guidance on how to be successful and how to have a sustainable team. Sometimes people will put teams together and they fizzle out over time, but these have all been in existence for a period of more than 4 years. So we're hoping to gain insights and our teachings in how to be successful. So when people do use the resources to start a team, they'll be successful and they'll be there for the long haul.
That's fantastic. Um, well, yes, thank you. You're getting so much praise in the chat. Everyone has
Oh,
been showing you so much love. So I do want to say thank you again so much. It's been such a pleasure getting to meet you and speak with you over the past few weeks that we've been connecting. Everyone, stay tuned. I will be sending out the slides and a recording of this event once the recording is available. So please stay tuned for that. With that, thank you, Sue, and thank you everybody for coming today.
Thank you, everybody, for being here and for taking care of your team. You'll never be sorry.
Wonderful last words. Thanks, everyone.